Good day, and thank you for joining us. I'm Russell Hendrickson. I'm the CEO of Practical Data Solutions. And today's webinar topic, Medicare 2021 Impact, Ensuring Revenue Cycle Integrity. Thank you for joining us today. And joining me for today's topic is our Vice President of Healthcare Solutions, Scott Everitt.
Thanks, Russell, and thanks for joining us today, everyone. I'm excited to go over this great topic with you today. You know, I'd like to start off today with all of the changes that occurred in the past year. A lot of times we didn't know what we didn't know, and so I'd like to start with a quote from Malcolm Forbes of, "It's so much easier to suggest solutions when you don't know too much about the problem."
And, you know, Scott, I would say if that was a true statement, we can just wrap up the webinar right here and call it a day. But in my opinion, Malcolm Forbes didn't live through a pandemic and all the changes that CMS and healthcare are bringing on us today. So, and that's what we're going to talk about today. So, you know, we talk about revenue cycle metrics in general, and there literally are hundreds of revenue cycle metrics your organization could manage to. And these are just a few of them here. And of course, as things change, we get even more challenged. So then somebody comes along and says, well, that's great, but we want to put all of those metrics, everything I need to know on one page. How do we do that? How do we consolidate what could be pages and pages of reports, different analytics, different even reporting tools, and how do we consolidate them down to make something that's meaningful and useful? Here you see a fairly simple revenue integrity type visualization, looking at things like coding and visits, NAR and denials, and maybe we've made, you know, credit balances kind of a standout because maybe we've had challenges with them. So what we're going to talk about today is how do we take a look at what are the right revenue integrity metrics, and then what's changed. In particular, our world has really changed in the last year and continues to challenge us. And so how do we measure and where do we start with understanding maybe what we should be re-looking at?
Last year, early in the year, we did a webinar around this where we talked about strengthening the bottom line. And really, we took a very business-centric approach to it because it was a normal period where we said, look, if you want to improve your bottom line, there's three ways you can do it. You can improve volume or see more patients. You can increase your reimbursement for the services that you're providing, or you can get paid faster. And really, any of those strategies will get you to the bottom line. Well, then COVID hit and the world changed. And all of a sudden, all of these strategies, they're still similar in a way, but they're not necessarily as applicable as they once were. In addition to that, the new CMS rule for the Medicare physician fee schedule for 2021 has made the most dramatic changes I've seen in my 20 plus years of healthcare. There's lots of things that have happened during this year, and including a few things like making over 140 services eligible for telehealth, which is a good thing and provides some challenges, but also some opportunities for practices that are out there. In addition to that, they did something that they've been talking about doing for several years in terms of revaluing the work RVU components of the E&M codes, particularly the outpatient E&M codes that are probably the most commonly billed by most practices. They've made some modifications to the practice expense RVU calculations, which are good things because they should increase the reimbursement that you're getting. But on the other side, they, in order to maintain budget neutrality, originally were going to decrease the conversion factor by almost 11%. Now, fortunately, due to the COVID relief legislation that was passed the last week of December, that is gone to just a 4% drop in the conversion factor. And we'll talk about it a little bit, but when you look at that 4% decrease with the increase in the RVU codes and the increase in the high volume E&M work RVUs, that's actually probably going to be a good thing for most practices. Most practices might see a slight increase on that, but it's going to impact different specialties differently, and that's something that the practices are going to want to take into account. And in addition to this, when we're talking about the E&M coding, they changed the E&M coding rules, and we'll talk a little bit about that, but they've made it a little bit more simple to feel confident in what you're doing, but also make it a little bit easier for the physicians to do the coding and make it more accurate with what they want to do.
So the significant changes that CMS put into place were first rolled out last summer, and we started talking about that both in some of the webinars we did and with our clients. This is a dashboard that we've showed before where we were helping our clients model the proposed changes, try to understand the impact. As Scott mentioned, right at the last minute with the new stimulus package, they softened the impact on the reduction of RVUs. But this kind of a change is unprecedented, the way that they handled changing RVUs. But, analyzing what we think is going to happen, especially when it hasn't happened, is a little different than where we are today, where now we're in 2021. We're seeing patients. We're under this new fee schedule. They just made more changes, the first week of the year. And we need to move beyond sort of, in theory, what we think is going to happen and start to analyze how do we measure revenue. So, I kind of look back, as Scott, you mentioned that 2020, what were we sharing? And it's a lot of this information needs to be tuned. It's just not quite as timely, right, as it was. So, we had talked about trying to increase volume, just see more patients, just bring more patients into the waiting room. Well, obviously, we can't do that. Space limitations alone may be a problem. So what do you recommend we're doing here now in 2021, Scott?
Yeah, so obviously volume considerations are things that are going to be important going forward, no matter what's going on in the world. But in 2020, we were thinking more strategically with the market and the panel sizes and things like that, where what we want to look at in 2021 is, are there more outreach opportunities with the way that we see patients? Do we have more flexibility in terms of telehealth and telephone? Can we increase volume because of efficiencies that come from that? And can we be a little bit more proactive, reaching out to patients who may be a little concerned about coming into the practice itself or into the office due to the pandemic? Are there ways that we can be proactive in reaching out to them and offering these telehealth services and things like that? So again, volume is a consideration, but it's a little bit different.
We talked about improving reimbursement back in 2020. Focus on denials, always important, but patient collections was second on our list. And obviously things have changed a little bit. So what do you recommend? How do we tune this strategy?
Well, right now with uncertainty in employment and people changing insurances, people moving insurances, people not having insurance, I think the biggest thing that people can look at right now is accurate coding. There's such a differential in the way, particularly with Medicare, how codes are going to be reimbursed differently. Looking at accuracy in that is something that definitely wants to be done. And we talked a little bit about denials prevention. We want to improve reimbursement. I think there are going to be real opportunities, particularly around registration type denials, because it's the first of the year. Medicare patients are changing the Advantage plans that they're on. People are changing new plans. They're resetting deductibles. They're lost job. Changed jobs means new insurance, and lost jobs means no insurance. And so there's opportunities for recovery that come from that. And then understanding the basis of the contracts that come forward and being able to model those.
And then the last year that we talked about back in 2020 was trying to get paid faster. Obviously, if we can move money through the revenue cycle quicker, and then our overall AR management. So do we need to adjust this strategy as well?
Well, I mean, it's similar because we always want those front-end lags to improve a little bit. And again, with the new simplified coding rules, you may be able to get your office visit codes in a little bit quicker even than you might see. But in addition to that, we talked about accuracy with our patient registration. But in addition to that, really valuing our AR and looking at what we think it's worth and the cash value of what we think is collectible versus non-collectible, and making sure that we're as efficient as possible in going after those collectible accounts.
So let's cycle through these topics and talk about it from an analytics side. So this is a dashboard that we talked about and was first showed back in April and May. But as we were working with clients, our goal was to make sure that we had dashboards that would encompass and help us understand what's going on with telehealth, which was for many cases a new service for organizations, and telephone encounters, and then also monitoring patient satisfaction and understanding what's the impact of these sort of changed way of patient access. And of course, then looking at reimbursement, are we now getting paid on those visits? Obviously, whenever there's new changes to reimbursement or from CMS, sometimes it can take time for those reimbursements to come through. But we want to probably move beyond what you're seeing on the screen here into something that's more visual, tells us a little more of what's really going on. We probably need to dig a little deeper than that infographic dashboard you were looking at. So, Scott, do you want to walk us through this visualization here?
Yeah, so this is a visualization put together in a tool. This is in Tableau. which is one of the more common visualization tools. And this is kind of a standard patient access dashboard that you would see in a lot of places. Now, even with all of the changes, we want to make sure that our providers are booked as efficiently as they possibly can be in their schedule utilization. So, you can look at their volumes and you can look at their booking rates, but you also want to break down how is it that the patients are accessing them. Are they accessing them via telehealth or telephone? And really understanding how those can be reimbursed, sometimes a little bit differently depending upon payer. There are some efficiencies that can be gained by that, but understanding how your providers are working can really be a key that way. But I think as we go through and really want to understand more, I think what we want to look at is the year-over-year change in comparisons that are out there, where we might want to look at a change in our schedule utilization. How have our providers been able to capitalize on these increased efficiencies that may be out there? And so if we look maybe Q1 of last year to Q1 of this year and try to say, are our providers still being efficient with their scheduling patterns? Is it something that, are there providers that aren't doing so well, and who are those providers that we can look at? And really, when you look at it, how is that changing in their RVU productivity? So I think looking at the changes year over year is something that will definitely be very beneficial in trying to benchmark the providers against themselves.
Yeah, and I think it really goes to where we're not efficient in our utilization. We may have to look a little deeper. This is just one example of a dashboard, and I'm going to explain a similar dashboard coming up where, do we need to look at patients potentially where we could be doing annual wellness visits? And so one of the changes that CMS made was they do now include annual wellness visits as part of telehealth and make it a reimbursable service. Or is it just that we need to be doing outreach on these patients to try to fill schedules for physicians? And can we start to predict or understand what is the potential if we can increase those schedules? The other area we might want to use our analytics is to look at chronic conditions and patient follow-ups. And maybe we haven't been able to proactively manage them, but as things start to solidify, we're still going to be limited to how many patients we can put in the waiting room or how many patients we can see in our offices. So we're going to have to look creatively for other ways to do that. So just one example of that. Let's shift gears and talk a little bit about some of the coding changes and what that might look like in a dashboard. And so here's a fairly simple numeric dashboard looking at an individual physician's RVUs. We have just their coding levels, and we're looking at trends of coding. And then we might even be showing things like patient satisfaction scores, and do we have charges outstanding, or any of the sort of controllable metrics. So Scott, how might we update this, or what would you want to highlight today as we move into 2021?
Well, as I look at this dashboard, the first thing you're going to want to look at is the elimination of code 99201. And that's no longer a billable service to Medicare. But that said, we do want to look at these coding patterns that are out there and take advantage of the new rules that are there. Now, a lot of times in the past, providers would tend to maybe play it safe, so to speak, and bill most of their stuff in the level 2 and level 3 areas. That doesn't have to happen anymore. Coding rules from CMS have become much more simplified, and really, even if it's the desire of the practice or the provider, they can be entirely time-based. So CMS has set these new coding guidelines that have come across as to what can be utilized. And when we talk about time spent on the visit, it's not even just face-to-face time with the patient, but it can be time spent looking at test results, time spent looking at images, time spent in consultation with other providers or a care team. All of these things can be used in coding the visit. So what this does is it helps us to, one, be more confident, and two, be more accurate with the way that we're coding. And so what we would expect to see is that providers would start to see some changes in the way that they're coding year over year once again as well.
So again, let's dig a little deeper into that data. And here you can see we have a visualization that's looking at E&M distribution. And the first thing that we may want to consider to do is looking at our current year, which is this brown bar here, and comparing how is that coding versus our prior year, right? Especially given the increases in reimbursement, but also given the changes potentially in how we can code.
Yeah, so one of the things that I look at when I'm looking at this particular dashboard is, can you see with the RVUs? So look at the provider RVUs that you might see there on the top. You can see with our highest RVU level providers that most of them are in that level 3, level 4 type area. And so looking at those coding patterns can help us get a better view. I bet if we look down at the lower RVU providers, we'd see several of the providers in more of that level 2, level 3 range, which is okay because we know we're being accurate with that due to the new coding rules. But when we are looking at that, what we'd want to do is make sure that their scheduling templates are reflecting this so that they can see if they're seeing patients more quickly, they can see more patients in an hour, and those volumes are reflected a little bit more accurately. So one of the ways that this can help us out is if we look at something like cycle time. And when we're doing cycle times, what we're talking about is the amount of time that the providers are actually in face-to-face with the patients. So if you look here, you can see someone like Mike Allen, where it shows that Mike Allen is spending a lot of face-to-face time with his patients. And so that would be something where we would expect to see higher coding patterns from Mike Allen. We would want to make sure that we would audit that, because if he's in that level 2, level 3 range, then he's not necessarily in compliance with coding rules, and that's a training opportunity that's there. In addition, with Duana Rodriguez spending less time with the patients, that's fine. We would expect to see the lower codes coming across, but we'd expect to see a higher volume of those based upon the schedule that's created for her. So these are ways that we can put all of this together to make sure that, again, there are some efficiencies to be gained, but also that we're as accurate as we can be with regard to the coding.
So I think it's quite interesting that in the past, we've talked about cycle times as a way to be efficient in utilization and sort of maximizing physicians' calendars. And yet with the changes to E&M coding, the thought of looking at cycle times and the time spent with patient against E&M coding really presents itself with some opportunities. So let's look at, here's another one of those opportunity dashboards. And I just want to walk you through a little bit. This is looking at coding opportunities. And this is a methodology that we use to predict potential revenue if we can improve. So what we're doing here, though, is we're looking at the activity of a physician. How many visits are they seeing? What is the new patient ratio? And then we're comparing each physician. So we're looking at the reimbursement, the expected reimbursement of each physician based on their payer mix and the total reimbursement. Then from here, we can create what is the potential revenue per visit. And in doing such, we can start to analyze which physicians have room to improve. They're below the average or the median of all the physicians in this department. If we extrapolate further, then we can start to look at what is the financial opportunity of the physicians here. And we can start to understand where we might want to focus the physicians to really improving on the coding, especially with the increases in reimbursement. There's going to be more opportunities here. So we're really understanding what are the bottom 20% not doing. We can identify who is best practice, and we can then start to model those physicians and their behavior or those opportunities to raise our reimbursement. And it's really a question of tuning and having the right reports to get us to that. Let's talk about productivity. And given the change and the significance of the change to what's gone on here with CMS and Medicare, you have to be very careful. This is probably the biggest area we're working with clients right now, is that you can't just look at 2021 RVUs against 2020 and potentially be meaningful without understanding the significance of the changes.
Yeah, so like you said, Russ, this is an area where a lot of our clients have come to us even just this month and said that they want to be able to look at their RVUs a little bit differently than they have in the past. And so what they want to look at is they want to be able to maybe value their 2021 services with the 2020 RVU tables. And what that's going to do is it's going to allow them to really gauge their productivity a lot better and try to understand what are the increases that are due to actual increased workloads and what are the increases that are due to kind of the artificial inflation of RVUs due to the valuation of the codes from CMS. So this is something you could put together where what you see here is just family practice. The work RVUs went up as you would expect from year to year, but when you revalue over the 2020 codes, you can see that the RVU productivity actually went down. And so the work-adjusted variance that's there shows you kind of what was the artificial inflation due to the coding changes, and it's something that we can work with our providers to do. We do a lot of custom work with RVUs sometimes, and this is something that I think is going to be very helpful for people who are really trying to gauge what's the true provider productivity increases that they're seeing.
Again, without good analytics, if you have a large number of physicians, multi-specialty, you really need to be able to do this sort of apples to apples comparison. And unless you've got the calculation set up or the reporting tools, you're going to struggle with that. Going a little further, and we talked about this in one of the previous webinars, but be very careful with benchmarks. Benchmarks from last year, given the changes, may be meaningless and in some cases misleading. So if you're like most organizations that show physician productivity and you bring in an external benchmark, and you don't readjust or consider where that benchmark is going to fall, you may very well set a benchmark. The physician looks like they're performing at or above benchmark, when in reality, productivity could be down or have been adjusted. And of course, you also then want to think about comp plans that have any kind of RVU component or tiered component for hitting goals. Be very careful in evaluating your current reports against those benchmarks. Shifting gears again, let's talk about maximizing reimbursement, Scott, and dig a little bit more into what you shared as some of the strategies in the beginning of the webinar.
So we talked a little bit about payer contracting, which that can definitely be something different going on with all of the changes that are out there, and understanding the basis of contracts that may be negotiated this year. You may have contracts that are based upon current year Medicare, or you may have contracts that are going to be renegotiated, and they may say they want to renegotiate against 2020 tables, or they want to negotiate against 2021 tables. It's really important to be able to model that out. 2021, even current year Medicare, like we said, with the way that RVUs have changed, that can actually be a plus for most organizations, but it does impact specialties very differently. If you have a lot of radiology, if you have a lot of anesthesiology, there's going to be some negative impacts to those. And so it's really important to be able to model those contracts out and model those proposed fee schedules to really understand what you're taking for that. And then, of course, denials is always important. And then AR management, we talked a little bit about. And in particular, what's changed is with patient collections, where patient collections may be difficult this year. The unemployment rate is higher. People are changing jobs quite a bit. Again, it means reset deductibles. It means new deductibles. And so what's really important is being able to look at the charge resolutions that you have out there. What is it that you're getting paid for? What are you adjusting off? What's out there in active AR and what's out there in denied AR? And really, once you get a handle on that, making sure that you go in and value your AR. What is it that we anticipate will turn into cash, and what is it that we anticipate probably isn't collectible? You may get a nice surprise from that, but understanding that will help you be more efficient in going after what you deem to be collectible accounts and collectible balances that are out there, and looking at that anticipated cash so that you can make sure that your budgets are adjusted based upon cash flow rather than off of revenue that hasn't been valued accurately.
So shifting gears, Scott, you mentioned denials certainly as part of cash collection and the impact of denials, and we really feel denials is going to be another key area for revenue integrity for a number of different reasons. Statistically, the average claim denial rates run 5 to 20% in an organization, but sadly only about 30% of denials are appealed. So that has a real significant impact on lost opportunity and lost revenue. If we look a little further, this is one of the infographic dashboards that we have in the PDF library. It's pretty clear showing, what are we getting denied on, what percentage of claims are clean. We can start to see those things where we're working on what are denials that are preventable and being able to categorize denials. We'll talk a little bit more about that. So understanding really what denials are we causing versus what denials maybe we can't control or fix. And then, of course, the all-important denial recovery. How are we recovering after we have a denial, and are we actually collecting the money or spending the effort to get to the money and then get the results? So let's dig a little deeper into denials, because this is a fairly involved topic here. And Scott, let's talk through a few of the key things that we think are important to watch this year with all the changes that Medicare is bringing us.
With all of the changes, really not just Medicare, but also the pandemic, most organizations have a dashboard that looks kind of like this, where they can track their volumes and their trends, and they can look at payers by your denials by payer, denials by division, department. They can look at the likely sources and try to understand what's their fault versus what's the payer's fault versus what's the patient's fault type of thing, front office versus back office. But really, I think if we want to make that next step and start relying upon denials as a way to improve our revenue integrity, we got to take another step from this one.
So as we dig down a little bit, I think there's really two key metrics. You can see there's quite a few on the page here. But the two things that I would highlight, first off, is that we have to be able to match denials back to the period that the charge was billed. So looking at denials in an unmatched fashion really isn't telling us what's going on. So we need to understand here, if we're in this September time period, what are the denials that are coming in September against July, and by then having them recategorized into the period they were billed, we can get a true what is our denial rate. So we can really start to measure monthly what's going on. And so when we start billing in January and February, right, being able to match in March what denials are from January versus February, we can start to measure, is our denial rate climbing? Where is it climbing? Why is it climbing? And then on the other side, the other key metric I'd like to highlight on this screen here is this clean claim rate. Being able to understand how well are we doing in getting the claims through where they're not flagging or getting denied or delaying payment for any reason. And so those are really the two key metrics that I would stress to highlight as we move into this year with all the changes from Medicare and the other payers.
Yeah, I think in addition to understanding these rates and these volumes, I think it's important to understand what happened after the denial as well. What are our denial resolutions? What's getting paid? What's getting adjusted off? What's still sitting out there in active AR? And being able to track that way, that helps us to track appeal efficiencies. Are we spending time on the right denials trying to get those paid, or are there particular denial codes that pay better upon appeal than others? And should that more be our focus? Are there particular payers that pay better than others, and should they be our focus? And so really trying to look at these resolution trends is something that can definitely help us find some efficiencies and gain more dollars in this year. But really, there's a lot out there. Denials has a lot of different metrics, and we could spend a lot more time on this.
So related to that very message, spending more time on denials, what we've elected to do is make this the focus of our February webinar coming up. We're going to dig down into this very category, is understanding denials and managing through them, so you can see in much more detail some of the metrics that we were just talking about and highlighting. But let's get back to what we're talking about today here, Scott, and let's start back to that dashboard we first put up on the screen. And how would you say this might be useful now that we've looked through and talked about some of the different changes that Medicare and the pandemic have brought us?
I think this dashboard does what we talked about without being too overwhelming. Again, you can have 100 different metrics on a page, but you can't manage to 100 different metrics. So looking at the key changes and where we think the greatest opportunities for this year are going to be, you can put together a dashboard that looks like this, where you're looking at your changes in your coding patterns and understanding where there may be opportunities for improved coding, especially with it being a little bit easier to do and being more confident in the accuracy of it. Looking at our AR management and where we can spend our time, both from an aging standpoint as well as from a payer standpoint, and what is a collectible account and how efficiently are we getting those, and are we getting them more quickly? And then of course denials, which impacts both our level of reimbursement as well as how quickly we get paid. And so anytime we can find prevention opportunities, we should look for those, and then when we can't, we should look for recovery efforts. Understanding a lot of times if it's our fault, that's probably where we should start with both efforts if we're doing that way. Again, registration denials in this particular year, I think, is something that we need to make sure that we're watching for spikes, and again, prevent where we can and recover where we don't.
So Maslow said, I suppose it's tempting if the only tool you have is a hammer is to treat everything as if it were a nail. And we're working through this webinar. I really think the messaging I would send here is, if you have a tool and we look at where the changes are and how we're using those tools in our analytics, do we really have the right tools to sort of treat, analyze, and focus on some of the topics that are coming up? I found one quote that I really thought fit both what the challenges we're facing, but I also thought they fit some of the challenges that we as a as a country and even a world are facing today. And this is from a physician at Brigham and Women's who wrote in his book, "We always hope for the easy fix, the one simple change that will erase a problem in a stroke. But few things in life work that way. Instead, success requires making 100 small steps to get it right." And when I think about analytics and building data warehouses and the kind of things that we do here at PDS, it really is small steps of having the right metrics and the right reports and the right data. And as we start to understand what's going on and we can analyze that, we can start to build out dashboards to communicate, or we can analyze and predict what we're seeing happening and then measure results appropriately. And it really is a lot of small steps and pieces and metrics put together. So kind of leave you with that as a thought as we move forward. All right. Thank you, everyone, for attending. Please have a great day and do stay safe.
Hey, thanks, everyone.